Dr. Lisa Pickett when we were walking in my neighborhood. And it took me a long time before I found out her interests, what she does, what kinds of resources she might be for us. And I'm delighted now that she has been willing to come today to talk to us about some of the issues, challenges in palliative care. Lisa has a long background in medicine. She has a resume that's longer than she looks. She started her medical schooling at Harvard, and that's where her medical degree is from. And she has done a number of things at Duke University Medical Center, including being the chief medical officer for 11 years. So Lisa comes with lots of good credentials and also a good heart. She has a wonderful dog. I love her dog, Izzy. Izzy and I are friends. So Lisa, come on. Welcome.
Good morning. It's really a privilege. And yeah, we have had a wonderful time getting to know each other, walking in our respective neighborhood, allowing me to walk in her neighborhood, really, with my dog and sometimes members of my family. And if I had thought better about it, my last picture wouldn't be the one you see of a rainbow, but probably would be my dog, who I love, actually. And I've enjoyed getting to know Diane and, well, her children, but her grandchildren too, which I am certain if you know her for 5 minutes, she's told you about because they're precious. So it's been lovely. I have driven past this church for decades and thought it seemed like the most welcoming place. And I noticed during the pandemic that the church also was very faithful to put signs out in front of people's homes that they were missed or that they were welcomed. And so I have always had a really warm feeling about this place and this space. But this is the first time that I've really had the privilege of coming into this building. So thank you so much for the invitation and the welcome. I attend Yates Baptist Church in Durham, just a little ways down the boulevard here. I hope that our church is as warm and welcoming as this one. You all would be welcome at any of our events as well. So thank you, and I'll try to be as casual as I can be while making sure I speak into the microphone. And if you can't hear me, wave or do something, and I'll be happy to adjust. So I do have a pretty eclectic background, and as I come to you today to talk mostly about finding your voice in sharing what you think is important, what's individually meaningful to you with the people around you about your wishes in the case of illness, your life, the end of your life. I thought it might be helpful to hear a little bit about palliative care and what I do, and the reasons that I enjoy palliative care and find it so important. So I hope you'll indulge me in telling you about my unicorn history. And this will I'm going to share my friend Brenda, who I didn't know was going to be here today, and I worked together for a long time, 1.5 years ago, a little partway into this journey. So she knows part of this. But I came to Durham in 1994 as a surgical intern at Duke Hospital. It was the first time that Duke Hospital had actually had 2 women in a surgery year, because the chairman at that time said that women should not be surgeons. In fact, it was a waste of time to train us. And since we have another woman surgeon in the room, perhaps more, sharing that, in fact, we make pretty darn good surgeons. So I came here with every expectation of training in surgery and in critical care, which was my first love along with surgery, and then probably going home to California or somewhere else. But life, takes some funny turns along the way. So I did my fellowship, And then I had fallen in love with a wonderful man who was actually my Sunday school teacher at Yates. And so I thought maybe I ought to stay in this area. And so the job available to me then was at Duke Regional. And it was in Durham Regional and County Regional, or County Hospital, for those of you who might have lived in the Durham area for a long time. And I said, well, it's going to be tough to do that job. And I was one of the first general surgeons there and critical care and building a program, but I loved it and had a really wonderful time. It's a very home-like place. It's like family. And I understood what it was to take care of patients sort of from a long period of time. I enjoyed that a lot. And then over the years, I found out that I enjoyed leadership and had the privilege of serving as their chief medical officer for several years. And ultimately moved back to University Hospital in Durham to be their chief medical officer, and as well as do critical care in the surgical intensive care unit. And during that time, I learned a lot about the importance of voicing your wishes. And that came from being a leader and hearing different things I'll talk a little bit about. And it also came from working in the ICU, where I saw people come in suddenly. I frequently worked the night shift. People would come in suddenly with an acute illness. And despite having some underlying chronic things, it was just profound to me that no one had ever talked with them about what was important to them before. So I just tried to put the pieces together in the middle of the night when they were too ill to talk to me. And I began to think how important it was to talk about your wishes. I'll kind of talk a little bit more about why, but after 11 years as the chief medical officer, which is a long time in chief medical officer years, kind of like dog years, and with the addition of a pandemic, I really needed to think about things differently, and thought a lot about different jobs and different opportunities. But I thought what was really important was helping patients to identify what was important to them and to take care of symptoms and things that were bothering them. And all of that added up to palliative care. And I'll talk a little bit more about what palliative care does here. But I became a fellow in palliative care medicine last year at Duke. For those of you who know what PGY is, it's postgraduate year, meaning how many years after medical school you are. So an intern would be PGY 1, resident would be PGY 2 to whatever. And most fellows are, PGY 5, maybe PGY 7 or 8. I was PGY 29. Perhaps one of the oldest. But I did have to go back, interestingly enough, and have all my notes co-signed by an attending who was approximately the age of my oldest child. And there are certain orders, like a do not resuscitate order, that only attendings can write. I couldn't write those last year. So there were a lot of very interesting aspects to being a learner at that age. But it was 1 year, I learned a ton. I had a great time. And now I have come and returned to be a recycled faculty member, recycled attending in palliative care. And so I want to talk about why go back and train in palliative care. Well, I'm a really firm believer that learning is lifelong. The fact that you're here means you are too. Great job. It really doesn't end at college or graduate school or at any point in time. I learn something new about every 15 minutes, and I'm grateful to the people around me. My grandmother taught me, if you didn't learn something today, you wasted the day. I agree with that. But as a leader, and particularly as a chief medical officer of approximately 1,000-bed hospital, I sat in a lot of meetings where I heard, with my leader hat on, challenges. We had patients that came in with certain expectations. You come to Duke for the miracle. This is not a Duke things, UNC too, Wake Forest, the whole gig. You come to a big university hospital because you expect a miracle. You expect something big and glowing and perfect. You expect a cure. And sometimes that's just not possible. And so what ends up happening is we do more and more and more things to you, and you stay a long period of time, or long LOS, or length of stay, really long time. You might die in the hospital. You might not be happy or content. Your family may be traumatized by seeing the things that were done to you and that it didn't help you. And I really began to think, we can do better with this. We can do a much better job of helping people voice what they want, what's important to them. And so from a provider standpoint too, and I felt this a lot during the pandemic, when you're doing things to people and you know it's not going to help them, you really know it's not, it makes you feel less compassion for the next patient over time. And so our healthcare providers, all of them, respiratory therapists, physical therapists, physicians, nurses, chaplains, everybody, they know when it's not helping too. And so I think encouraging our community to improve their ability to talk and voice is actually going to create more compassionate care in the future. It might not help us. It might help our kids or grandkids. So, what does palliative care do? Some people think that we just provide hospice care. And that's a little bit of what we do. I love delivering hospice care. It's one of the greatest privileges of my career, both in the home and in the hospital and in an inpatient hospice facility. To be with someone at the very end of their life's journey is a privilege. But that's just a little bit of what we do. So palliative care is a multidisciplinary group of people, because physicians alone cannot do this. It's nurses, it's physicians, it's advanced practice providers, it's a social worker, it's volunteers, and it's our chaplains. And we work together because you cannot help anybody with just one dimension of care. So we're a whole team, and we do two main buckets of work. One is we help with symptoms, whatever that is. If that's pain, constipation, trouble sleeping, anxiety, all those things, anything in that bucket, we're really good at helping. We don't have magic, but we're really good at it. The other bucket is that we help support patients and their families with decision making in really complicated times where there is not a right and a wrong answer. It's what's the best decision for you with the information you have at the time you need to make that, knowing what's important to you. And so we're good at that, and we're kind of specially trained to anchor all our decisions in what's important to you. And will this achieve the goal that you want to achieve? And then, we think about how to do that in the context of the medical care that we deliver. I talked a little bit about this. Medical care, we want the win. We want to save lives. We want to do high-end procedures. Duke just did the second, artificial heart implantation and save somebody's life. That's what we want. We want to cure cancer. When you get your cancer cured at Duke, there's literally a bell. You get to come and enthusiastically as you want, ring that bell. And when you get your cancer cured and you're a kid in the bone marrow transplant unit, which I think is the hardest place in the hospital, bless them, you get a confetti parade. So it's awesome. Let me just, I'm not a crier, but if you survive watching some little kid skip out of that bone marrow transplant unit getting confetti thrown without a tear, it's quite a thing. But that's what we live for. We want to make that happen, right? We want the win. But we want it anchored in what's important to you. The reality is, sometimes patients come to us, they want the win, but they end up just staying a really long time. And then sometimes they end up in a nursing home, which is okay if that's okay for you, but not okay if you've always said, you can do anything, but I never go in there. So it's all based on what's important to you. Also, we see families, we talked about, that have distress, and a patient who spends time maybe getting chemotherapy or maybe having a surgery, that maybe didn't have a high chance of helping them, when really they would have rather been fishing or at the beach or visiting their grandkids and watching a soccer game. Oops, sorry, I moved too fast. I talked about the multidisciplinary team that we work with, and that has been kind of the most stunning thing to me in my fellowship, is that I can help with pain on a physical level. But there is a lot of suffering out there that has very little to do with the physical aspect of pain. There is psychosocial pain, meaning I'm separated from the people I love, I'm worried about the cost of my care, and there is a tremendous amount of spiritual suffering. Why did God allow me to be sick? You know, how did this happen? Or am I a good enough person if I'm going to die? And I'll tell you, our chaplains are an integral part of our team, because sometimes I go see a patient and I can give them all the Dilaudid or morphine that I want, and it is never gonna help them the same way as like Teresa Bayless, one of our rock star chaplains, coming in to talk to those patients about their spiritual concerns. And that's one of the things I love about palliative care. So I kind of hoped, because I'm the eternal optimist, that we would palliative care would help cure everything. It would make everybody feel better. It would create better communication between teams. It would put families on the same page, because families are always on the same page, right? And it would stop suffering. And that's the Rebecca Sunnybrook Farms thing. The reality is, it does. And this is for people who are interested in looking at data and statistics. It statistically improves your quality of life in many disease processes to have a palliative care team supporting you. Bone marrow transplant, lung cancer, there are some very clear-cut randomized studies that show that you will have better quality of life. And some that will show you will live longer, but it's not consistent across disease processes. However, it does not cure everything. It doesn't stop all suffering, it doesn't cure all terrible disease, and it doesn't put everybody on the same page all the time. I wish it were. Families that didn't have perfect communication when things were going well, it doesn't always go well when things aren't going well. But I talked about some of the things I love about palliative care. Because when I was working, I usually worked nights in the surgical intensive care unit while I was serving at University Hospital. And at the end of, figuring out their blood pressure, their pressors, and their ventilator settings and things, I would get to ask about them as a person. And it was like, oh, that's Lisa, she asks about that. But now in palliative care, I get to ask that first. This is great, I love it. I go in and I ask people what's important to them. And even in hospice, when someone comes in, even if they can't speak, I ask their family member, tell me what they're known for. What's important about them? What should I be aware of when I'm taking care of them? And I find that incredibly satisfying. What I think is important is that we continually ask the questions of, is this going to help me? Is the payment, and I'm not talking about financial, but is the cost in terms of bad days for whatever this treatment is going to give me enough good days after that? And that's different for everybody. And then every day, as good as it can be. I love that, because some days we just want you to be able to go do something good, something that you like, to feel better. And then to improve the communication as much as we possibly can. So, this is the same slide. I had my husband look at this, and he's like, you put the same slide in 3 times. I said, it's a communication technique, it's okay. And he would have probably come today, except he's volunteering in Western North Carolina. So what is important to you, and what should you take away from this, is that you put your values first when you're making a decision about your healthcare. So we're going to talk a little about that. If I could implore each of you to do one thing after today, just one thing. If you couldn't speak for yourself, who would speak for you? Make sure you have that defined. And if it's not the legally obvious person, Like if you have a spouse and that's the person you want, that's the person it's legally gonna be. It's not critical. It's nice to have the healthcare power of attorney, but that's not critical. But if it's not that neat and tidy, the biggest service you can do is fill out a healthcare power of attorney, which in the state of North Carolina requires 2 witnesses and a notary. That's an opportunity for advocacy later, because we need to make it easier to do. Yeah. Somebody who's trying to do it. It's too hard. Not every state makes it as hard as we do. I don't know why, but at any rate. That is really important. We as healthcare providers, if you come to us and you're sick, we really do look at those. We want to know who speaks for you, and particularly if you're in a family that might have differing opinions about what your healthcare should look like. Having that written down is really important to honor what you want to have done. So if you take nothing else away besides a good lunch, take this away. Make sure you define who's going to speak for you if you can't. That's number 1. And then you need to go to that person and say, these are my lines in the sand. And it is different for everybody. There's no right, no wrong. But where are your lines in the sand? Some people say, I would never want a feeding tube under any circumstance. Some people are like, yeah, if I have to have a feeding tube, that's okay. You know, some people are like, gosh, I would never want to live in a nursing home. Some people are like, as long as it's in my hometown or people come visit me and I would be able to speak to my loved ones, that's okay. And some people are like, if I can't just take care of my own affairs, you know, that's unacceptable quality of life for me. There is no correct answer here. It's what's important for you. And honestly, this changes over time. Because I think about things a lot differently than when I was 25 years old, for certain. And so over time, you want to have these conversations again and again about what your priorities are and what your lines in the sand are so that people can honor that. So then, this is a bit more nuanced, and I think a little bit more embedded in whatever medical diagnoses you carry, or if you have a new diagnosis. What is most important to you? Is it time, or is it quality of life? Because we can focus on one, and we can probably get you one really well, but you can't have both, and they're trade-offs. And I will give a personal example. So in our Sunday school class, sadly several years ago, 2 of our class developed metastatic pancreatic cancer. They weren't from the same place. It was hard. It was a hard time. They chose very different pathways. Both were correct. One had a daughter who was a junior in high school and was a single parent. She did everything. She suffered and had surgeries and chemo and radiation and more chemo, and she got 1.5 years out of it. She didn't get her daughter quite to graduation, but that was her goal. She knew she wasn't going to live, but she wanted to see Katie finish. And she came close. And if you didn't know what her goal was, you would think that was pretty stupid. To like jump on the train of having all those things done. But her goal was clear. She was so hoping to make it 2 years. My other friend said, I'd rather just focus on quality. And she lived a shorter period of time, but it was better time. And it was exactly right, because it met her goals. So 2 people, same diagnosis, you knew the outcome, but they chose different pathways, and it was based upon their values and what was important to them, so it was right for them. So I think thinking about that in the context of any illness you come to, time, quality, and where does that land for you? And it will look different over time. You know, I recently had a patient that said, well, this doesn't make any sense for them to have X treatment. But I talked to him more and I learned more about his life. And and you've been hoping to have a grandchild for years and years and years, and they're going to be born in March. And we started the new treatment because I want him to hold that grandbaby if that's at all possible, and that's what he's hoping for, and he's willing to suffer. He's willing to give up the quality so he can hold that grandbaby in March. So you pray with me that it makes it in March. Ability to stay in your own home. That's one of those, things that you should talk with people about. Time with your family. Are you trying to make it to a grandchild, a special wedding? Think about those events, the markers. So second one, when you go to any healthcare provider, you should ask clearly about not just, will I survive this treatment, surgery, chemo, radiation, fill in the blank. But what will my quality of life be after that? What do you expect? And what in the best case would you see? And what the worst case would you see? So you can ask those things because you want to know what it's going to be like, not just if you live, but if it's acceptable to you. And then keep talking, because many of these things change over time. And I'll throw this in. We didn't put this on the invitation, but think about the times that most of you, I suspect, had children. And you have to have the sex talk, right? Nobody wants to. We hate it. It's like uncomfortable. It comes at uncomfortable times. Sometimes it's unexpected. But you have to keep having it because things change over time and their questions change over time. So sometimes you just gotta do it. End of life conversations, serious illness conversations. You hate it, you dread it, you put it off, and yet you have to do it if you want things to go well. And things change over time, so you have to keep talking about it over time. Okay, so resources. And I should have said I have no disclosures. I'm not financially attached to any of these. I don't think anybody is, actually, maybe. And this is not comprehensive. And then we can start a dialogue. But there are a number of resources to help you walk through what decisions might be, because it gets overwhelming at times. So I brought just one that you can pass around that I can leave here. There's something called 5 Wishes that you can go through if you want. I warn you, it's a lot of discussion and information. Don't try to talk about it all in one sitting. It overwhelms me, and I do this every day. But it just uses plain language to talk about who my healthcare agent is. Again, the importance there. And things that are really important to you over time. And it comes into those things I would want to do, would not want to do. So you can go on, and I think they have they charge you $1 for it or something online. It's not entirely free. I don't know why anybody's trying to make money off of it. But anyway, I'm gonna leave this here. You can look at it, see if it's worth your while. Welcome to. But it's just a guide to kind of help you talk with your loved ones about what's important. The other is there's prepare for your care and prepare for my care, and it's just different versions of the same thing, helping a loved one prepare versus you. And it's kind of that same thing you can do online. And then there's National Institute for Aging, help with advanced directives that gives you those. Advanced directives, I find as only moderately helpful, because basically the only thing they talk about is if you're in a persistent vegetative state, what do you want to have done, essentially? It's very rarely that clear. And so, like persistent vegetative state versus normal, and you need something that talks about the middle. So these, I think, are a little bit more user-friendly and plain language, but I'm not opposed to advanced directives either. The AARP website actually has a lot of nice resources on it, so you can kind of surf around and find things that work for you. And then, come back to talk to your loved ones and talk to your healthcare provider. It sometimes it's really hard because you have like 15 minutes with your primary care doctor, and that's approximately enough time to take your clothes off and have them listen to your heart and take your blood pressure. But they are the ones that can help you, and hopefully they've known you along your journey, and so they know a little bit about what's important to you. Let's just remind you of those things. I don't know if we want to stop there and have more dialogue, because I have a couple of slides here about like specific questions of do not resuscitate and hospice care, but you may have questions about having these conversations first, and so this might be a good pause time to have dialogue. And I am not the expert on everything. I may have to phone a friend, but I'm happy to at least dialogue about whatever questions that you have. Are you there? Who's going to ask a question? Yes.
Okay. What do you do with a power of attorney, a medical power of attorney, when you have someone with dementia and somebody who may have lucid days, completely lucid, and then other days when they don't remember your name?
Mm-hmm.
So how can they change as they go along?
Yeah, that's a great question. So I'll repeat it back to make sure everybody heard. Someone who has dementia and has good days and then not good days, and then over time has progressively fewer good days. And that really is partnering with that person's primary care doctor to say, do they have capacity or not? And so there are several things embedded there. One is that they should, again, this is good if you can get before that and have them define their healthcare power of attorney, and durable for legal stuff, but healthcare power of attorney, then that person kind of automatically takes over their healthcare decisions when they become unable to make their decisions, and usually it's their primary care doctor, or if they're hospitalized, the physician there that says, they don't have capacity, and so we're looking to this person to make the healthcare decisions. Challenges are, though, that with folks that are somewhere in the middle, it's very hard because you kind of have to have their assent to do things to them. We don't tie people down and force them to take medicines, and so it becomes sort of a working together as a team to understand what things you will and will not do. And that, that's for medications. Dialysis is a key problem in that state. And then for durable power of attorney legal stuff, that really becomes sort of more legal assessment. But healthcare power of attorney is usually with their primary care physician. And if they haven't documented a healthcare power of attorney before being less capable of making those decisions, once they're sort of sane as not having capacity, the next legal person is usually the one they look to, unless the person has a guardian, and then that becomes more of a legal. Did that answer the question, or is it a different question?
Yes, except that I know there are different types of dementia. There's Alzheimer's.
Mm-hmm.
The person I'm thinking about had an injury and is very capable many times of actually going back into complex physics formulas and has a whole lot of brain capacity.
Yeah.
So, can that person who still has a great deal of capacity with memory loss in a lot of areas, cancel a power of attorney?
If it really gets sticky at that point and they really want to do something, you're like, boy, that doesn't make sense, then you really have to involve more of usually a psychiatrist to actually have them evaluated. And the frustrating thing to me, and I love my psychiatry colleagues, but this is just the reality of what they have to do, is that sometimes, the bar is kind of low, and if you have some capacity, you have the right to make some decisions, and then they'll say, okay, they have capacity to make simple decisions, but not complex, and you're like, how do we define that? And it becomes hard. It's not black and white. And it really kind of is a relationship. Gosh, maybe they could make a decision to buy a blender and have a flu vaccine, but maybe they can't make a decision about having heart surgery. And that's when their healthcare power of attorney or next of kin, if there is one, comes into play. And it just comes down to, if you think they're doing something really ridiculous, then working with a medical professional to define that they don't have that capacity. It's sticky. Yeah.
Is there also, if someone doesn't have physical capacity, after a stroke, they're bedbound, they can't use their hands to write. And so my understanding is you then need 2 doctors to sign for them to not have capacity, but physical, is that your understanding?
I guess it depends. If it's that they just physically can't sign the form, but they're cognitively intact and can communicate in a different way, then you would just have a witness, saying they are unable to sign, and we're signing. Maybe I'm not understanding the question.
Well, the situation that I'm experiencing is the bank is requiring some things, and they're requiring for the power of attorney to be effective, that 2 physicians sign a capacity form.
Okay.
But the person is bedbound and can't get to a physician to do it, is the other part of it. And so it's really, I don't know, how do you do this?
That's a great question. So it's in the case of a person with a physical incapacity, but it sounds like they may not have capacity to do things either, and need to have a physician sort of certify that they don't have capacity. And it sounds like maybe for more legal things, but you can have a video visit. You can have video visits with patients these days. That's a lot of terrible things about the pandemic, but one of the good things is that you can have a video visit, and that could be a way to certify as well. There are a few doctors services that make house calls. It's pretty hard to get these days. But a video visit is usually sufficient to honor what they need for that. Yeah.
This is a more generic question. I'm trying to picture a conversation with my healthcare power of attorney and my children who are not on great terms, and my niece and nephew who live in the area, and my husband. And I'm picturing it. We're all listening together. I'm saying what I wish or whatever. I can't get any farther than that. I can't picture where we are. I can't picture who's facilitating the conversation when we get to loggerheads. And I wonder if you have any experience with setting up conversations and encouraging them.
Yeah. So the question is, literally the mechanics of, I want to pull my family together. Maybe my family isn't all on the same page, and you're trying to figure this out. And you're asking a perfect question. I swear to you, here's my idea. For every American family who will have a conversation at Thanksgiving, you prove that you had a conversation about what's important to you, and I'll give you a turkey or a tofurkey, whatever, I'm vegetarian, so, and set it on your table if y'all will talk while you're eating. I think, you have to find a way that works for you all. And coming together and saying, and even use this, we had a great conversation, and I hadn't thought before that I really hadn't told you what's important to me. And so I'm writing this down on paper, and maybe a few key points. You don't have to go through everything in all these forms. It's exhausting. But maybe you share things 3 or 5 things that are really important to you personally. If I'm ever really sick, I just don't want to be on a ventilator. Or I'm okay with living in a nursing home, but not if I don't know who I am anymore. That type of thing. Those types of whatever. You feel like there's all sorts of perfect answers here. And I really realized that I hadn't told you that. And I love you, and I don't want you to have any burden of decision making on you when I'm sick. So I'm going to tell you now what I want, and then when you do what I ask, no matter whether you agree or disagree, you don't have to feel any guilt about it because I'm telling you what to do. And I'll tell you, I had a patient in the last couple of years that sat with his daughter, and we were making very difficult decisions about his health. And he said, well, just ask her, you know, she'll when I'm sick, she'll do it. And she literally looked at him and said, please don't make me do that. Then I have to live with that forever. Just tell me what you want. And then I don't have to be guilty about it. I don't have to carry the burden that maybe I did the wrong thing. And so I think the language that you use is, I realize that I need to make this easier for you, my loved ones, whether that's family, friends, chosen family, whoever it is to you. I want to give this to you as a gift so that you know what I want and you don't have to carry any burden of guilt. Yeah, I hope that's helpful, because it is awful for family members who feel like they have to make a decision and they don't know what that person would have wanted, and then they wake up in the middle of the night every night going, oh, I hope I did the right thing. Yeah.
Not recently, but I have read stories of people who have DNR and it gets ignored. Or,
Yeah.
what do you have to do to make sure that it's followed?
You read my slide. So we can, oops, sorry, I just leaned on it, of course, and went backwards. So he said he's heard of people who have a DNR, or do not resuscitate. We call it do not attempt resuscitation, DNR, I guess because they wanted more letters. And it was ignored. And that's a really, really important thing to say. So, and I may take, if you'll privilege me for a minute, I'm gonna take a step back and say, what is a DNR and what isn't it? And then how do you share that information? So in general, a do not resuscitate order or request is that if your heart or breathing stop, you do not want someone to come and do CPR, shock you, put a breathing tube in your mouth, etc., and put you on life support. Now, some people will say, don't do CPR and things like that, but I have really bad lungs. I have COPD. That's a real common thing in this area. People have emphysema, and they get in the wintertime especially, and they say, you know what, I'm okay to be on a breathing machine for a few days. Usually I kind of get better and get back off, but if my heart stops, I don't want to do that. So it's either breathing and heart or heart, but at any rate, let's just go with the simple, if my heart stops, I don't want somebody to mash on my chest and put me on life support to try to bring me back. And that is a decision that's very important to share with your family. But if you feel strongly about it, your physician can also provide you with this form, and it's the North Carolina Goldenrod form. I think every state looks a little bit different, but this is your way of saying, I don't want to be resuscitated, and I'm going to put that up. Most people put it on their refrigerator because it's a kind of common place. So if paramedics come to your home and see it on the refrigerator, usually everybody has a refrigerator, they would, and it's, you know, your sort of family says, yes, that's correct. We wanted you to come help us. He was in pain or he fell or something, but we don't want you to resuscitate. Then they won't honor that. The times that I've seen where it's ignored kind of fall into a couple of different categories. One is someone's not sure that you're DNR, meaning you're at the grocery store and fall down or have an arrest there. If they don't know, they're going to make what they feel is a safer assumption. They're going to initiate a resuscitation. There are sometimes too that people come to the hospital and they get so sick that they can't voice it anymore, and their family gets scared or has a different opinion and says, I know, I'm taking their DNR away, go ahead and resuscitate them. It kind of drives me nuts. And then, yes.
If these documents are prepared in another state, are they valid here, or do they have to be redone here?
It's a great question. The question is, if documents are done in another state, are they good here? Usually they will be honored. This is one of those, you, as a physician, will look at things from other states and say, this is what they want, everybody's on the same page, and it's fine. If you're in some sort of family situation where there's a lot of argument about things, you would want to make sure that everything was translated into North Carolina. Now, ideally, and here's another opportunity for advocacy, why isn't it just the same across the country? We're all Americans. And that would be a great goal, but right now it all looks a little bit different. So if you had something and you used to live in New Hampshire and you're going to live here for the remainder, I guess it would make sense to go ahead and change it to North Carolina. But as a physician, either way, I would honor that as your voice if you couldn't speak for you. I'm going to come back to your question about when is it ignored. I think it's when people aren't sure that that's what you want right now. Like you don't have a sign on you, or if your family changes. And I think that's where it's really important to communicate your wishes to your family and to define a healthcare power of attorney who will honor your wishes even when it's hard to do that. And one way to make sure is that some people actually get 2 copies of this and they put one in their wallet or car or whatever and then put one up on their refrigerator. And then they tell their loved ones so that they know what they want and know that they don't want to do this. And then you should always, if you come into a new doctor, a new health system, make sure that that's what's documented in the record. So that we know and can honor. We should always ask, but just in case we forget, tell us. What else? Other questions?
I have a question. So what if and I think sometimes this is addressed at the time, but what if you have a DNR, but you have to have a port placed and something happens during the procedure? You know, you're not supposed to die while you're getting your port put in or whatever. Is that usually addressed before the procedure with people who have a DNR?
Yeah. So if you have a DNR order and you have a procedure, something that requires an anesthetic, even just sedation, not general anesthesia or anything, it should be a discussion point between you and the anesthesia provider or the person providing the sedation of whether you want to, we call it suspend your DNR. And most people would do that. And most people who provide sedation or anesthesia feel better if you do that because in their minds, what if I just give a medicine that you have a bad reaction to and we need to support you breathing with a breathing tube for an hour while we reverse that? They feel better about that. However, some people feel very strongly that if their heart stops or their breathing stops while they're having something, even if it was a complication of the medication procedure, they would not want to be resuscitated, then you can request to have the procedure without suspending it. So it is your decision to make. But it should be a conversation that you have prior to the procedure. And it's common, it's all in our electronic medical record. It should be visible to everybody. I didn't know how familiar you all are with hospice care. I get thumbs up, hospice too. Every day as good as it can be. It's like the hospice t-shirt. Hospice care, just to give a couple of lines about it, is care for people that if 2 physicians knew your medical history would say, you know, within the realms of this disease process took its normal course, they would not be here in 6 months. Now, we're not God, and we don't have the magic ball to look at, the crystal ball to look at, but it's to everybody's best estimate. So that's the criteria for getting into hospice. The vast majority of hospice is delivered in your home, and that can be your physical home structure, your loved one's home, an assisted living, a nursing home, and it gets you a hospice nurse, one of the most creative human beings on the planet, to come to your home at least once a week, review your medicines, make sure you have what you need, social worker who gets you all those cool things and helps you with psychosocial things, and a chaplain to talk about your spiritual support. I think this is like the best support that you could have, because it also includes a number that you can call 24/7 if you're having more symptoms or need something different. For those people who are at the very end of life and have very difficult to control symptoms requiring like IV pain medicines or nausea medicines or sedation, there are inpatient hospice houses. I put the picture of the Duke Hawk Family Pavilion. UNC has a wonderful, Transitions has a wonderful inpatient facility in Raleigh. There are a lot of great facilities for this, and they're wholeheartedly dedicated to the support and treatment of a person who has symptoms at the end of their life. And it is a beautiful place to come and deal with all of those different aspects of suffering for the person and for their loved ones. And they provide also grief counseling and support for the loved ones for a year after the passing. So that is the general sort of things about hospice. And I suspect that this group is keenly aware of hospice, but I always put a plug in, because I think hospice has the ugly evil, they've called in hospice, you must be dying tomorrow. And actually, you know, there are people on hospice having really good days, so it's not as evil an end of life as one would think. Questions about hospice? Yeah.
For most of these forms and decisions, you refer to the physician signing. If your relationship is more with the nurse practitioner or the physician's assistant, can they also sign forms?
Mm-hmm. Yes. Yeah, I should have said provider. I've tried to change my language to provider in most cases, but I must have fallen into old ways, yeah. But whoever your provider is absolutely fine. Yeah, nurse practitioners, PAs deliver amazing care, so. The only odd thing is that hospice works more with nurse practitioners than PAs, and that's logistics. Yeah, they can all sign. Other questions?
There's another question here.
Oh, yeah.
This is more a personal experience, but a few years ago, my sister called for me to come visit her to go over her will, her durable power of attorney, and her medical power of attorney, which was me, and the will executor. And I was like, oh, this is just so weird. But I did. And then 2 years ago, when she had a stroke and could not communicate, my other sister and I knew exactly the documents. We knew the attorney, we knew the CPA, and for a month, when there could be no communication from her as she was recovering from the stroke, we knew exactly what to do. Was it easy? No. I'm a nurse, and being on the side of the bed, as my fellow nurse Marge over here knows, and being the one to say no, if she stops breathing, do not resuscitate, is very different from my being the nurse and counseling. So it's very challenging. But because we had had that conversation, I knew exactly where things stood, and at least it took away some of my uncertainty. It did not take away my grief, but it did take away some of my uncertainty about how to proceed. And she was one of those that the dementia came and went. And during her lucid times, I pulled out those documents and went over them. We could talk about bank accounts, and it was amazing the things that she could remember and tell us and guide us during those lucid, it was hours, not days, but lucid hours that she could help us. So I was thankful to have had that conversation.
Thank you for sharing that. That's beautiful that she had that much trust in you, and and that much love for you that she would share that with you. So that's really a tribute to you and to your relationship with her. Oh, sorry.
Yeah, can you speak to the fact that if you're in a assisted living or a nursing home and you have dementia versus if you're at home and even if you're on hospice care, that if the person you love is still eating, opening their mouth, taking food, that in the nursing home or assisted living, they're going to continue to feed that person versus if you were at home and you could make the decision to not do that. Because that's what happened with me with my mom, and it was, I thought it was cruel to continue to put food into her where she was clearly dying, and I was at peace with her death after watching her for 14 years go through this. And I was told the only way to really control that was if I had her at home, which I did not at the time.
If you couldn't hear, thank you for sharing this. Just so difficult experience with your mother and dementia, and the difference between being in a nursing home where they are almost really legally required to just continue to force feed is a strong term, but really continue to try to nourish. Whereas if you're at home, you can have more latitude in saying, if you want it, great, if you don't. And I think that's true. I wonder if including hospice, which is more and more accepted to include hospice in the care of patients with dementia, which I think hospice is the best support, and I wish we had it for, anyway, we're expanding criteria as a nation for dementia because it less linearly follows a trajectory than, say, cancer does, pancreatic cancer or something like that. But we have learned some things, and you're correct. People lose their appetite, and it's their way of not engaging with the world as much as they used to. And we used to put feeding tubes in them, and I'm certain as a general surgeon, I must have at some point put a feeding tube in, and now, thank goodness, for good research that looked at this. And for patients with advanced dementia, putting a feeding tube in does not extend their life. So we actually say that it's not just, well, it's probably not a good idea. Now we say, actually, it's wrong. Actually, we shouldn't do it because it doesn't improve their life. It just subjects them to a procedure and to the discomfort and to having something in their body all the time. And I wonder if including hospice care more in the nursing facilities might also help with staff education, but also looking at metrics from a national standpoint. And I think that's where I look as a healthcare leader and someone who's interested in palliative care. How do we change the metrics? Because the metrics that they're following is weight loss in their patient population, right? And sometimes that's okay if it falls in line with their goals of care. And we should not hold nursing homes to those standards that we kind of have to right now. And so they treat people differently rather than treating them as people, individuals. Yeah.
What I'm hearing is that there could be some differences between how you're treated in one state or in another state. I'm familiar with a friend in Northern Virginia that I'm assisting now, and I'm familiar with this idea of being in a nursing home and being allowed to not eat. In fact, to be told that this is now hospice and that's the way we're going to go. How do we decide for ourselves where we want to be if we have different children in different states that are saying, come live with me, you know? How do we decide where we want to be? Do we have to look at the laws in those states, the facilities?
Yeah, that's a great question. I mean, some of it is you want to choose the place where they have good health care, but sometimes, you know, you need to go where your children are or, you know, their loved one or wherever you're going to go for family reasons. And I think that's where being very specific in your healthcare wishes may help you. Because if you say this is, you know, my goals are X, not to be force-fed, not to have a feeding tube, you know, those types of things, you're more likely to be treated the way that you want to if that's clearly documented when you have the capacity to state that for yourself. And then making sure that the family you're going to go live near is fully aware and understands your specific wishes. And I think that's the best. That's not a perfect answer. I think that's the best we can do. I would love it if we had national standards for the care of elderly and seriously ill patients, and that, well, I have a lot of feelings about nursing homes, but to make the ways that we can make them better, and not leave people there just alone for long periods of time. Yeah.
When I worked in the hospital, I became aware that very often we were doing care for people who it wasn't doing any good. It was, you talked about futility of care. And what I learned then was that physicians weren't really being protected legally for stopping fetal care if the family was asking for it. And I was wondering if that's another area of potential advocacy.
Yeah, I absolutely agree. And that's where voicing your needs and your wishes in writing, and who your healthcare advocate is, and that they understand that is so important. Because we have people all the time receiving horrible, futile care. And once something gets started, at least in North Carolina, and I cannot speak to every state's laws, but in North Carolina, directly pulling something off, dialysis, ventilators, etc., even with the agreement of every medical professional that this is futile care, if their family member, their representative family member demands it, it becomes a risk for that provider to be held liable, both criminally and medical malpractice. And it is contentious in this state. And there's a huge opportunity for improvement in our laws that would legislate that. And so yes, that's something I'm interested in pursuing a great deal. In the meantime, stating what you would and would not want and who you want to direct your care is the way that you can keep yourself safe from that.
So, just a follow-up, if I'm hearing you right, if the family is not demanding the care, and if the physicians agree that it's futile, everybody's okay if we stop?
Absolutely, absolutely. Yeah, there are usually steps that we take to make sure. So we do this frequently, right? We say, they've not improved on, I'm going to make something up, the ventilator. They're not improved and it's been a week. There's no improvement and we don't expect any. And the family says, they wouldn't want to continue on. The healthcare team says, that's correct. We don't think they should continue on. It's just, kind of causing suffering. Then everyone can agree and we can compassionately, with appropriate medication and things, remove the ventilator. That's fine. It's when the family wants it and everybody else thinks it's
What
futile.
about when the physician wants it? I mean, once in a while, you do still find physicians. I mean, I think this is changing, but once in a while, I think we still find physicians who really want to keep pressing on. That death is failure for the physician.
Yeah.
When obviously we're all going to die.
Yeah.
But what's the role of the advocate in that situation?
I think that's just requesting a new physician. I see a lot less of that than, that's the honest truth. That's the
Fire the doctor.
Get a new physician.
Yeah, I think finding a different team, I see a lot less of that than I do the other way around in my practice, but I may have a skewed practice. Yeah, but you can find it different. There's no reason that, the only time I guess I would say differently is if it's a child and, there are a lot of instances where if it's literally a child that the courts may step into that.
Sure.
But I think that's a different setting.
I think what you're doing can make a big difference, particularly if other people do it as well in speaking to public groups, speaking in churches, and I know it happens, but I think we need more of it. I've been wanting to do something with Being Mortal, Atul Gawarde's book,
That's a great book.
ever since it came out.
Yeah.
So I think that sort of thing would make a difference.
That would be a great journal club book. I hadn't thought of that. I mean, I love the book, but I hadn't thought of it as like a journal club thing. That's a great idea. No, I appreciate the invitation because I think, sometimes the place where you're comfortable talking about this may not be in a big conference center or on a Zoom or in a, some kind of, or maybe even in your physician's office. This is your faith community. These are the people you love and you sit in church with all the time. And this is a comfortable space for you to think about these really hard topics.
Right.
Yeah. All right, the gong's gonna, I see Diane giving out.
I want to know if there are other questions.
Any other questions? For Diane or for me? Either one. I'm on for her. All right. Truly, thank you very much. You guys have been wonderful, and that is a symbol of hope. That is a beautiful rainbow after a big rainstorm when my family was together, all 5 of us in Puerto Rico.
Many thanks, Dr. Pickett. We really appreciate your time and your wisdom and your knowledge and your caring. All a gift to us.